This time on the procedure.
The human heart. Roughly the size of a clenched fist, this vital engine supplies nourishing blood to all corners of the human body. The heart is powered by coronary arteries that lie on its surface. If these arteries become blocked due to plaque and/or calcium, it can lead to a heart attack or even death. For much of human existence, there was no treatment for coronary heart disease. Heart patients were subjected to a life of bed rest, simply waiting to die. But thanks to pioneering physicians, surgical options began to appear in the late 1950s. Bypass surgery started repairing vascular issues outside of the heart. The invention of the heart-lung machine made performing bypass surgery possible on the heart. And by the late 1980s, balloons and stents emerged as a new non-invasive treatment alternative. Today, these endovascular devices are still being refined, techniques perfected. A giant leap has taken place in imaging that has allowed doctors to visualize and understand this disease even better. And, for the first time in history, doctors are finally understanding and appreciating how the disease can manifest differently in women and among various social and racial demographics. Today, we'll be taking you into the endovascular lab so you can see these new technologies and techniques firsthand. Advancements that are changing a past death sentence to a new lease on life.
The procedure is made possible by educational grants from Abbott Laboratories and Siemens Healthineers.
The brain surgeons are considered to be the real leaders in those days. But then when heart surgery came along, we were cast in a different role again as almost a genius quality.
Well, I think one of the major developments was the development of the surgical treatment for aneurysms of the aorta, particularly thoracic aorta. And we did the first successful operation for an aneurysm of the thoracic aorta here.
During the time that I was in Houston, a lot of exciting things were going on, development of heart-lung machines, new kinds of equipment. We began to work on different methods of coronary revascularization, and of course, one of the things that was occurring then was the coronary bypass operation in its very, very earliest stages.
Almost every case that we operated on was a reportable case. It was new, it was different, and it was exciting and interesting to everyone.
Welcome to the procedure. I am Brad Perry here with Dr. Rizik, our second one that we're doing together.
Absolutely.
So this is exciting.
What'd you think of that last?
That was amazing. That is history right there that you're actually a part of.
Those were the pioneers. You know, if you think about it, those were the pioneers in Houston. That's where a lot of the pioneering work in heart disease was. At the same time, the space race was really centered out of Houston. But when you saw DeBakey and Cooley, those are the founding fathers of heart disease management. And then you saw Dr. Dietrich, who's a disciple of DeBakey and Cooley. And I'm honored, I'm a disciple of Dr. Dietrich. So I feel very much connected to what you just saw in that clip.
Yeah, and does that make me now connected to them?
Absolutely, absolutely.
You know, just seeing that kind of history and now seeing what we're going to be doing here with this, let's walk through this a little bit because this is such an important procedure, not just now, but even going forward for some of these patients.
Well, to understand what we're doing now, it's always important you have to understand where we were. These were rock stars. These open heart surgeons in the 50s, 60s, and 70s. You saw they were on the cover of Life magazine, America's Super Surgeons, that was the caption. These doctors were so innovative, but almost everything that was being done up until the mid-70s was surgical. It was open heart, it was open chest. Really, by today's standards, more invasive. Now, open heart surgery is still a great technology, but that's the only thing that we had back then was open heart surgery.
Yeah.
About the mid-70s, about 1977, a Swiss radiologist, Dr. Rizik, placed a small balloon inside a coronary artery and opened that artery, and we were off to the races with this whole new catheter-based technology of balloon angioplasty, and it eventually gave rise to stents and all of the modern technologies we have today. You know, back when I first started as a cardiologist, when I was in training, all we had were balloons. That was the only technology, that was the only non-surgical technology we had to open these blocked arteries. The problem, Brad, is that the arteries would close 30, 40, 50% of the time because you could dilate them with the balloon, but then the blood vessel would recoil. In 1994, the FDA approved stents. And as we talk, stents are very small devices. They look like a spring on an ink pen. They're about that size. And that was just an incredible leap in the technology for us to be able to maintain the integrity of the artery so the artery wouldn't close 40% of the time like it did with balloons.
Yeah.
And then in 2003, yet another quantum leap forward in the technology where we began to coat the stents with drugs. Chemotherapy drugs, just like that which we use in cancer treatment. And by coating the stent in chemotherapy, with a chemotherapy agent, we lowered the reclosure rates associated with treating arteries, treating coronary arteries, down to just a couple of percentage points. So it's been such a meteoric evolution from those surgical pioneers that you saw to modern stent technology. It's been remarkable. It's been an incredible run.
Yeah, I know we have a couple of stories that we're going to be showing you out there, but before we get to those, I want to talk very quickly the difference between women and heart disease and men and heart disease.
There's nothing more important in the last 10 to 20 years, more important than the recognition that women and men can present very, very differently. The classic chest tightness, chest pressure that we talk about associated with coronary disease, women don't always have those symptoms. Women can have very different symptoms. They can have shortness of breath, more subtle symptoms of discomfort in the arms, in the back of the neck, sweating. When a woman comes into the office, and we're going to see some examples of this, when a woman comes into the office, you have to be vigilant. You have to listen to what women are saying to you, because we've been programmed only to consider what the symptoms are like in men. There was even a study called the Framingham study out of Framingham, Massachusetts, that suggested that women don't get heart disease. So we've really had to change the traditional thinking on men and women and heart disease. This is a change that was absolutely necessary several decades ago.
Hi, my name is Ann, and I live here in Fountain Hills, Arizona. I worked many different varieties of nursing. My sister had cardiac disease. My mother had cardiomyopathy. Probably back in 2008, because of the cardiac history in my family, I had asked my primary physician if I could please have a scan done, and he did order a CT of the heart, where they found out that I did have some blockages. In October of 2017, I began to have problems with jaw pain. In fact, I had had 2 episodes of emergency room runs where I'd had tests which were always just not enough to prove that I had any problems. The jaw pain and the neck pain and the shortness of breath became more of a problem, to the point where I could hardly go out for a walk. So I did ask for another opinion. I went to a doctor who did an angiogram on me and found that I had severe heart disease. I was supposed to have open heart surgery, but then when the open heart surgeon came in and said, I can't do it 100%. I can't do it, you don't have enough vein material. I said, well, I just don't want to go through all of that and not have it done completely. So that's when I said, I will have to call in Dr. Rizik. He came in, of course, and said, sure, I can do it. And that's when it all started.
Anne presented with left main coronary artery disease. The left main coronary artery is the main artery which supplies blood and nutrition to the heart muscle. A blocked left main coronary artery is a very high-risk situation for a patient, and performing left main coronary intervention is a high-risk procedure.
Previously, the only way to treat something like that was thought to be open heart surgery or a coronary artery bypass surgery. Now, with our technological advancements, with the skill set that we have, we can oftentimes treat this left main coronary disease without open heart surgery and can actually do it in a minimally invasive approach through coronary stenting.
As part of her evaluation, we did an ultrasound or echocardiogram of her heart, and I saw that her heart function was abnormally weak. As a result of this discovery, noticing that her heart muscle function was weak, we knew that she would be at much higher risk for complications related to doing a coronary intervention.
To do the procedure, we had to put an Impella heart pump device so that we can support the heart muscle while we are doing this complex high-risk intervention.
The Impella is a medical device that aids in the pump function of the heart in a patient whose heart is so weak that it may give out during a medical procedure.
One of the other technologies that we used is called a rotoblator. A rotoblator is sort of like a drill. She had a severe amount of calcium in the coronary artery, so we literally had to drill or rotoblator through that calcium so that we could perform the stent procedure. Studies have shown that using the Impella device when you perform rotoblator or perform left main coronary intervention makes the procedure a much safer undertaking.
Oh, I was back to it immediately. It didn't take long before I was able to walk and do normal chores without getting out of breath, and no more neck and jaw pain. I just think that it's important that patients have doctors that listen to them, and if they're not happy with one doctor, that they should always move and get a second opinion. Heart disease is the #1 killer and still is. Men have such a different symptoms, and maybe they're listened to, but women with heart disease just need to be listened to, especially if you have a family history. My plan is to live day to day and live for the moment. I'm here a year later to show you that it does work.
Doctor, what amazing story there.
Isn't that amazing?
Oh my goodness. And imagine that literally right now they're just rewriting medical books for women with heart disease.
Absolutely being rewritten so that we understand that women have been underrepresented in terms of the diagnosis and management. There's definitely been a discrepancy, and we've only begun to learn that in the last decade or so.
Yeah, so you're telling doctors out there, listen to when women come in and talk about their chest pains or their problems that they're having.
There's no question that the emphasis has been placed on listening more carefully. Historically, when you talk about the chest tightness and the chest pressure, as you and I have spoken on the show, that may be more representative of what men have when they have coronary disease, and was very typical of the symptoms women have but people just weren't listening. And I was blessed to get to know her.
Wow, that's amazing. And we're seeing the technology change now too into making sure that people are getting taken care of the right way, especially what we're standing in front of right now.
You know, you have really touched on a great point, and that is the technology. Our ability to image these coronary arteries, to look at the greatest detail in the coronary arteries is very important. The X-ray technology we have from Siemens is phenomenal.
Yeah. What do we have right here?
Well, as you and I have spoken about, X-ray technology alone is not enough. And so we have the ability to look at the coronaries in very, very minute detail. This is called OCT, or optical coherence tomography, and it is an infrared type technology where we're not only looking at the arteries from the outside of the body as it is to the left, but we can go inside the artery with a small camera and look at great detail in the blood vessel. This is what the normal blood vessel looks like. The vessel is made up of multiple layers of cells packed together, and you can see these layers of cells packed together in this image. So as we are looking at the blood vessel on this picture here from the outside, this is looking at really a normal artery on the inside. And so we use OCT when we are performing stent procedures. And I want to show you just how valuable OCT can be. Once we place a stent, we want to optimize or perfect the stent placement. It's more than just putting a stent in. We want to perfect the stent placement. We want to make sure when we place a stent, as you see here, these are these little markings, as you see all around, that's the stent up against the vessel wall. If we fully expand the stent and it's up against the vessel wall, as it's shown here, full expansion, those patients usually have a very durable result. Those are the patients who are less likely to come back with stent closure. But we can use this camera to look at other areas. Now look at what we're seeing here. We see here the stent is not fully expanded. In fact, it looks like it's just hanging out in the middle of the blood vessel. If we don't optimize that stent expansion, go in there with another balloon, when we see this stent not fully expanded, those are the patients who may come back with stent closure and need another stent procedure. We call that in-stent restenosis. In medical terms, we want to avoid a stent not optimally deployed, and you can see that is not an optimal stent expansion, whereas right here, the stent is optimally deployed, and that's something that we want to try and achieve when we place a stent.
Wow. And we're going to see this in the operating room.
This is from Abbott Vascular. It's called optical coherence tomography, or OCT, and we're going to show you several pictures like this when we do our procedure. We use this every day.
Wow. This is amazing, doctor. All right, let's switch gears a little bit and let's talk about this next patient.
I know where you're going.
Yeah.
Sometimes, we have great technology, but sometimes it just boils down to the human touch, humanity, and how we touch people's lives just through our effort. Forget the technology for a minute. Sometimes it's just not giving up on a patient.
It does not appear that there's any kind of an effort up there yet. Now remember, oh my God.
Oh my God.
That looks like a second plane.
16 years ago, on the first anniversary of 9/11, I had this heart attack.
Think for a minute what you were doing on the first anniversary of 9/11. I know my family and I had just gotten back from a memorial service at church, and we had just gotten home, and I was sitting at the piano with my eldest daughter, and I got the call from the emergency room that a patient had just arrived and he was having a heart attack.
My dad, he passed away quite a few years ago. He had a massive heart attack. He went, lay down in the bed, 10 minutes later, he was gone. But he was sweating, just sweating beat the band. It kind of stuck in my head. So 2002, on 9/11, all of a sudden I started sweating. And I thought, uh-oh. I said, okay, Diane, let's go. We gotta get some help, because I remember my dad sweating like this. I need to get some help. Something's going on. And we didn't even call 911. Get me there as soon as you can. And I was in there for about 10 minutes answering their questions, and all of a sudden, my eyes rolled right back in my head, and I was gone.
2 first responders who happened to be in the emergency room saw his eyes roll back in his head, and he suffered a cardiac arrest. And it was amazing. They just jumped right in. They didn't hesitate, they didn't wait. We had started doing CPR in the emergency room, and these 2 first responders came with us up to the cardiac catheterization laboratory, because we didn't have a full staff there yet. And they did CPR on this patient who was completely flatlined with no blood pressure and no pulse for over 45 minutes.
Most patients that have cardiac arrest and have a rhythm that is a flat line or asystole usually die.
I think within the context of this being the first anniversary of 9/11, they knew their brethren in New York didn't quit, and they weren't going to quit. They were dripping wet, they were sweating, they were exhausted, they were fatigued, but they didn't stop. They weren't going to give up on this patient. It was truly one of the most amazing things in my professional career to witness.
If you've ever done 5 minutes of CPR, you would understand how exhausting it is to do 45 minutes of CPR. I was a soccer player during my college years, and 45 minutes is an entire half of a soccer game. So doing CPR for 45 minutes is pretty remarkable.
As we moved along in the case, after about 45 or 50 minutes, all of a sudden we saw a blip on the screen. And then one blip was followed by several more, and we realized we had a rhythm back, and before long we had a blood pressure back. And as he began to stabilize, I wish you could have seen the look on those 2 first responders. They were elated, they were ecstatic. I think the fact that it was 9/11 was all the more special for them.
I just feel fortunate that I'm even sitting here right now. Because if it wasn't for Dr. Rizik and those true paramedics, I would not be sitting here right now. The one paramedic came up to my room, and I really wanted to thank him. I actually wanted to take him out for dinner or whatever. And he said, no, this is what we do. And he said, we're just going to leave it at that.
What an amazing story that Jerry was going to die 16 years ago, but he's had a whole new life since then.
From the time that I was released from the hospital up until now, which was 16 years, I've been able to actually see all 3 of my grandchildren. I would have never been able to see them at all, and they never would have been able to see their grandfather if I didn't make it.
This has given him a second opportunity at life. This reads like something out of a Hollywood screenplay. In my own personal career, this is not something that I could ever anticipate happening again. This is beyond what we normally expect from anybody providing CPR.
Some of us are extraordinarily fortunate that the right people are around at the right time, and I think in Jerry's case that was definitely the moment to have 2 people like the firefighters help him, as well as one of the best cardiologists in the country right there to help him as well, I think are the keys. And then it can show that even people who are critically ill, if we give them a chance and they recover, they can go on to enjoy great things in their life and even accomplish more than they ever thought was possible before.
I have no problems. The stent is still in me, the same stent. I just been enjoying life. I look at life a lot differently in this past 16 years because of this situation. This was a big awakening as far as my life was concerned.
Welcome to another procedure with Dr. Rizik and his wonderful team here. Doctor, this is such an important procedure we've been talking about because you know the history behind this. It's amazing. Before we start, let's introduce the team again.
Well, we have a great team. We have a lot of clinical support from industry, from Abbott Vascular, from our friends at Shockwave. We're going to do a very interesting balloon dilation. We're going to use an Abbott Vascular Xiant stent, one of the time-honored great stents in our armamentarium. We're going to do some imaging with OCT. You know, if they say it's not fun to sing alone, it's not fun to do intervention alone. I got my partner for many years, Dr. Mullick Shaw. Dr. Shaw heads much of our program. While I direct the lab, Dr. Shaw heads our program. And we're going to have Dr. Bimal Padalia in a minute doing some of the high-resolution imaging. And it's great to have you. We have Mallory right next to us and an ensemble in the room. And then the other thing is, so much of the support for our education and research program has come from Siemens. They've really helped to sponsor these live events. So our friends at Siemens Health and Air, we're just so appreciative to them.
Well, I'll tell you, we are very appreciative because this has been a life-saving for a lot of our viewers, a lot of people watching. So let's get right to see what we're seeing right now on the screens.
May I orient you to how we are? So Dr. Shaw has what we call the access. He's got the catheter in the blood vessel. Dr. Shaw, you want to point out what you've done?
Yeah, so absolutely. So when we need to get to the heart, to the blood vessels that are feeding blood to the heart, there's two access points that we historically go through. One is through the leg, and the other one is through the wrist. When we go through the leg, it's great, but sometimes people have to stay in bed for a long period of time afterwards, or they can bleed from their leg, and that can be catastrophic. Dr. Rizik actually maneuvered a catheter through the wrist, through a very tiny, tiny incision through here, and then we were able to go into the heart here right now. So what we have right now...
Well, let me just 1 minute.
Yeah.
So the head of the bed is this way. This is the foot of the bed, and you can see that the access site is actually in the wrist. So we've gone up the wrist all the way to the heart, and we can access all the arteries of the heart right through the wrist.
Wow, and as we were showing before we came into the surgery room about this procedure and how it's important now instead of having to go in and do a full bypass.
Well, this is not bypass surgery. This is not an open chest procedure. Historically, this type of procedure for arteries would have been a quadruple bypass, would have been the domain of the surgeons.
Absolutely. Before, when you have multiple vessels that need to be fixed like that, surgery was the only option for patients. And so now, with this coronary stenting procedure, we can get people recovered faster, recuperating faster, and feeling better with a tiny, tiny incision, just like the one we've shown you here.
Wow, it's amazing.
Well, if you look at the screen, Brad, you can see the blockage that we're looking at. Could we get a stop action with the artery completely full? We are injecting contrast. Now toggle back, perfect. That's contrast that we've injected in the artery, and you can see that this artery, this right coronary artery, is a C-shaped artery, and right in the middle of the C, you can appreciate there is a blockage. When you compare that area of blockage to what we see high up in the vessel and more distal in the vessel, that's about a 90% blockage.
Yeah, absolutely. And this is a really important artery because it feeds all of the blood to the bottom of the heart. And so we really want to make sure that that bottom of the heart gets enough blood flow.
So what we're going to do, we're going to proceed with first ballooning it, dilating it. We showed you what stents look like. We're going to stent it in a minute. That stent is a scaffold. It's like a spring on an ink pen, and we're going to scaffold the vessel open, and then we're going to bring Dr. Padalia out here to do some imaging to show what the vessel, we were looking at the vessel from an x-ray on top. This is the x-ray tube, and we're looking at it from an x-ray outside the chest. Dr. Padalia is going to show us what it looks like from inside the vessel with what we call optical coherence tomography, or OCT.
So with that, that is where you're going to go in and you're going to actually open that up so it can start flowing more. Now, is there actual blood flowing right now, but not as much? Is that what the problem is?
Now it's blood flowing through there, but if this gentleman were to go jogging, he would, when the heart rate increases and you need more blood, what would happen?
So when you need more blood and there's a blockage, there's not enough blood flow that can go through there, and then people can get chest pain, shortness of breath, feel like they can't do as much. And so that's why it's really important to fix these blockages when they're severely tightened.
What causes these blockages, doctors?
Wow, complicated formula. First of all, it's about fat and cholesterol, plaque, but that's only part of it. Coronary disease is about inflammation, and people develop an inflammatory process. They develop inflammation inside the blood vessel, and that can predispose. The older you are, the more calcium you may have, diabetes, smoking. It's a complex cascade of events which leads to the development of disease. And in his case, he had 4 arteries blocked. This would have been a quadruple bypass.
Absolutely. Absolutely. And that would have been something that would have had a long recuperation period.
And let's remind people, before this actual technology right here, you guys were actually going into opening up the chest and the heart to do this type of surgery.
In the old days, most of these types of procedures were bypass, were open chest procedures, and now we're going into the wrist. Now, because there is calcium in this artery, we're going to do something unique, something new. You know how when a person has a kidney stone, doctors can use lithotripsy, shockwave lithotripsy, to break down the calcium. Dr. Shaw, when you see calcium here, what does that mean when you try and do an angioplasty or a stent?
So that makes it more difficult. So you can imagine if you're putting a balloon or a stent into something that's very rigid, it makes it more difficult to put in that stent. And then sometimes if you don't treat that calcium well in advance, you don't get as big of a stent that you can put in there. And that leads to an increased risk for a reblockage or a stent that's not completely opened up. And so that's why it's really important to, 1, recognize that there is calcium, and then 2, try to treat that calcium in advance.
So it's sort of like bone growing into the arteries. So what Dr. Shaw is going to do is he's going to advance a lithotripsy balloon, and we're going to administer shocks inside the vessel to try and modify that calcium, to open that calcium. Go ahead, advance it. And that's our balloon. Of course, it's in a deflated state.
Looks like it's close to where we want it to be.
Yeah, I think that's perfect.
Wow.
Wow.
Bring it back
Very
just a
good.
touch.
Okay, now Mallory's going to step in, and she is going to inflate the balloon, and I'm actually going to administer shocks or shockwave lithotripsy to the, okay, ready? Go negative. Now, Brad, watch what we do, and go up to 4 atmospheres. And now you're going to hear some shocks as we go in and try and pulverize the calcium.
Wow.
Now, you hear those beeps?
Yes. And I see the little piece moving there. Is that what we're seeing?
Now it's opened up. The balloon is opened up due to the shocks. Okay, and down, balloon down. Now we're going to give a little bit of rest. We're going to allow blood to go through the vessel again. We're going to wait a second. And let's just give him a few seconds to recover from the first balloon inflation. And we're going to do another lithotripsy run. Let me just inject a little contrast, go live. So, okay, come back just a hair. Perfect. All right, go back up. There it is. Oh, there you hit it that time. That's great.
Wow.
So watch. We're going to do one more after this. I think we'll do a series of 3. And balloon down, please. Okay. We've done 2 inflations. We're going to let him rest. Sometimes what we can do is we can watch his EKG, and as we inflate our balloon, remember, we're obstructing flow. We're blocking flow into the vessel. And so they might have a little chest pain. They might have some EKG changes. That's perfect. Mullet, go up right there. We're going to go up with the balloon again. You can see the balloon inflating.
Yeah.
And now, again, I'm administering shocks to the vessel. You did a great job. I think you hit it right on the money there, sir. And down. Okay, we're going to take this balloon out. So, Floro, retrieve it. Is it down? Yes, sir. Okay, good. So now we're going to take the balloon out of the vessel. So what we've done is we've pre-treated the blockage before stenting. We don't want to wire. We don't want to try and put a stent in where there's an obstruction.
Right.
And so what we're going to do is take the balloon out now after pre-dilating it. We'll take a picture to show what a good job Dr. Shaw has done with his balloon angioplasty, and then the next thing will be to put a stent in.
And now with putting that stent in, that's going to leave it open, as you were saying. It's almost like pushing everything aside so it can move much.
That's right. It's a scaffold that will help to maintain the integrity of the vessel. When all we did was balloon angioplasty several decades ago, we could get the vessel open like this, but about 30, 40, even 50% of the time, the vessel would recoil and close, and the patient would have to come back for another procedure. Now with stents, the closure rates, especially with the Abbott stent, the Xiant stent that we use, the closure rates are low single digits. They usually stay open.
So compared to our last procedure, this is moving kind of quickly. Is that just because of the type of surgery this is?
It's the type of surgery it is. Dr. Shaw and I have worked together for many years. We know each other's movements. And so this is, a lot simpler. So what we're going to do now is take another picture and see what the balloon has done. Wow.
Oh,
now,
my goodness.
That looks fantastic. Now, let me just tell you something.
Wow.
If the year were 1990, before we had stents, we would probably be slapping each other high five, walking off and saying, look how great this is.
Yeah.
Now, I want you to look. It looks better than it did, but we're going to improve the result even more by putting that stent in. Now, watch how much better of a result we can get. 3533, please.
Now, I hear you calling out numbers a little bit. What are those numbers you're calling out to?
Okay. So the stent, I said a 3533. That means the stent, when we dilate it, it's going to be about 3.5 millimeters in diameter and about 33 millimeters long. Now, when you zoom up on that, look at it in relation to my finger. That's the stent right there. That shows you just how small these coronary arteries are. Now, that's the difference between stenting and surgery. The surgeons use magnifiers to see. We magnify our picture on the X-ray with X-ray machines.
Yeah.
Okay.
Rizik, you want to talk a little bit about what's coded on the stent?
Great point. Well, why don't you?
So, historically, these metal objects are great in opening up arteries, but sometimes you can have tissue that forms on them over age and time and cause a reblockage. And so industry and innovation has been fantastic in finding actually a drug coating that can go on these metal objects that allows for less of a reblockage rate. So in fact, it's decreased the risk of reblockage from about 20% down to less than 5% at times. So that's fantastic.
So initially, the stents were just metal, and now they're drug-coated metal. And what's very interesting about this is the initial drugs used were just chemotherapy drugs. The same chemotherapy drugs that we used in cancer chemotherapy to prevent cancer from cells from regrowing. This will help to prevent the cells from regrowing inside the stent and the stent closing. So we have this scaffold which keeps the vessel open, and then these anti-inflammatory chemotherapy drugs to keep the vessel open. So Dr. Shaw has just advanced that. He's done it flawlessly. He's done a beautiful job.
And I want people to understand on your screen, when you see the two different black marks, that is the stent.
That is the actual
so understand
stent.
That's the actual stent in there.
That's the borders of the stent.
And that helps us use
I'm gonna take that from
X-ray
you now.
to identify exactly where we want to put the stent.
So now look at the picture that we showed you before. I'm going to show you how the vessel looks now. That's perfect, Malik. That is absolutely perfect. Okay, so now watch what we do with the stent. This, as we dilate it, will end up, push the table away from me just a little bit. Away from me, perfect, perfect. So I'm dilating it slowly, and you'll see the stent, the balloon on which the stent is mounted, start to dilate, Now it's fully expanded and looks very good. All right, would you take a cine and let's show it?
Absolutely.
Okay, now look at that. So that is a lot bigger than what the blood vessel was after we just ballooned it. What Dr. Shaw is going to do now is he's going to withdraw the balloon, and the stent is still there. Now let's take a picture, shall we?
Yes, absolutely.
Okay,
Hold on 1 second.
so with the stent in place, now watch what it looks like.
Wow.
That's beautiful.
So go back
Oh, my
2
goodness.
pictures, and just for the audience at home, go back. Now, this is what it looked like. It's still a little bit irregular. Go forward a picture. This is with the stent being inflated. Go forward another picture. With the stent fully inflated and in place, Those irregularities are smoothed out. The vessel looks fantastic. Now, I said that the stent was going to do a better job. I think we can even do a better job. I told you the stent was a 3.5 millimeter stent. What we're going to do now is put a 4 millimeter diameter balloon, and now we're going to try and make the vessel oversized, because the more we oversize this, Brad, the less likely it is that our patient is going to come back with the vessel closed.
So are you putting another stent in, or?
We're going to put just a balloon and now expand this stent even more. So we had a stent on a balloon, we put the stent in place, and now we're going to put a larger balloon. We're going to go from 3.5 millimeters to 4.
Yeah, and everything's flowing much better. They're going to be able to move and exercise and be much healthier.
No question. So what Dr. Shaw has just done flawlessly, again, I might add, is he's put the balloon inside the stent. Why don't we take a cine to see where we're at?
Sure.
Run it forward. Okay, negative. So, back just a tad. Okay, happy?
Yeah.
All right. So now we've got a balloon at 3.5, or a stent at 3.5 millimeters inside the artery, and now we have a 4 millimeter balloon that we're going to blow up and expand the stent even more.
Wow. For those watching at home, if you just saw what that happened, you saw the balloon open up a little more to the stent.
So now he's going to pull it back a little bit so that we dilate the entire stented segment. Can we go in just a tad?
Let me just sit just a second here.
I'd go in just a tad. Just a tad in. Perfect. Dr. Shaw and I have worked together for so many years. Sometimes we do this and we don't even talk.
Hand in glove.
All right, and now you see the balloon. Now you see that balloon expanded, and it's expanding the stent. Okay? So, I think the next step is for us to put a camera. Now, you've seen all these pictures from an X-ray camera from on top of the patient's body. Now let's put a camera inside and see what it looks like inside the blood vessel.
Wow. So like what we were doing outside here.
Absolutely, what we showed you before we came in the lab.
So, wow, amazing.
So Brad, the number one thing that patients ask me all the time is how long will my stent last? And two things that Dr. Rizik and the whole team are doing here, which are really crucial, are one, making sure to prepare the blood vessel extremely effectively with that shockwave technology that sort of actually opens up that artery with the lithotripsy. And then the second thing is to image it afterwards to make sure that the stent is perfect. Because if we want to make it just right now, and that decreases the chances of ever having to need another stent in the future.
So Brad, I'm pleased to introduce one of our colleagues and a close friend, Dr. Bimal Padalia. Dr. Padalia will be over here in a second, but Dr. Padalia, what is it that we learn from OCT that helps us to optimize these stents, to make these stents stay open or to be durable so that they don't close down?
That's a good question, David. So what OCT allows us to do, especially in 2020, is not to guess on the stent size anymore. It's like Goldilocks and the Three Bears. You want the stent size to be precisely right, not too small, not too big. And we know that through studies that when you do get it close to exactly right, it decreases the risk of further heart attacks in the future and problems with the stent.
That's a perfect explanation. So we have the OCT in. Fluoroscopy is great. We have used fluoroscopy for decades to look at these vessels, but fluoroscopy alone is not enough. There are limits to how well we can see the blood vessel with fluoroscopy, and as Dr. Padalia said, putting this tiny little infrared camera in really does give us more ability to image and to perfect the stent implant.
So how big is this little camera that's going in there?
About the same. It's smaller than the stents that we put in.
Wow.
Okay, let's do an OCT run. Ready? Tell me when you're ready. Hold it.
So I'm auto-calibrating. You purged
Flush.
a little bit. You're well engaged. Is that right, Malik?
Yeah.
Yes.
Yeah.
Say that again, Bibble.
Yeah.
You're well engaged?
We are.
Yes.
We are. Yeah, we
And
are.
what's the assist on?
414-300-0. I'm going to leave
Zero
it a little
rise.
loose here.
Okay.
You okay with that?
Okay, ready?
So this is how we get the OCT image.
I'm going to bring it back.
Enable pullback.
And if you'd fluoro save that for us. Okay, watch the rhythm. Okay, why don't you come back?
Good image.
Now, Dr. Pedalia, I really want you to explain this because you explain this so well. Talk to us about the image we're looking at and the stent and whatnot. Tell everybody in the audience just exactly what you're seeing.
So we basically have put a very small camera into the artery. It's as if, we've shrunk somebody, become like Ant-Man, and are swimming through the artery here. So on the left-hand corner, you can see the fluoroscopy or the X-ray image that we've been looking at. And then to the right, you're actually swimming through the artery as going from the far part or the distal part to the proximal part, or near part. And these spokes that you see, these white dots, they kind of look like bicycle spokes. That's the actual stent that's been put in. And as we interrogate or look at this very closely, what we can see is how well did we place the stent in the right position, and how big did we make it? Did we make it significantly large?
I'm sorry to interrupt you, and it's right up against the vessel wall, isn't it?
Exactly. The stents, the metal part of the stent is right against the metal wall, which you can see right here. And then the important part is how large did we make it? Did we make it sufficiently large enough? And these numbers in yellow here tell you that we're 99% expanded here, 87% expanded there. And we know that the studies show if you're more than 80% expanded, that you've done a very, very good job, and that this stent may last the patient for a long, long time.
So all I did was talk. Dr. Shaw did all the heavy lifting. He expanded the stent. But what we can conclude from having this tiny camera inside, we can see things that we couldn't see with X-ray alone, and we can conclude, based on your measurements, that this is very, very unlikely to ever close, correct?
That is correct. This is how stents should be placed in 2021.
So as long as this patient stays, now we just put a piece of metal in the artery, and so we're going to ask this patient to be on blood thinners, 2 blood thinning agents for 6 months to a year. As long as he stays on those blood thinning agents, Dr. Shaw, chance of closing is low single digit.
The risk is very, very low if somebody's taking their medications regularly, which is great.
So let me ask you, we just saw the imaging. Now, say for instance we got through and the numbers weren't right where they were supposed to be. Do you go back in and you maneuver so those numbers are just right?
Absolutely. We'd touch it up to make sure that we're expanded perfectly and go back in with the camera to make sure that we've actually done it perfectly as well.
Dr. Pedalia, maybe you can talk about some of the upcoming artificial intelligence with this device, and it tells you just how much you should expand it, right?
Exactly. It's similar to having maps in the past, and then having a map that talks to you and tells you exactly what to do. So the next level technology with this software, OCT, when you do a run, it will actually tell you what kind of plaque do you have. Is it lipid or cholesterol rich, or is it calcific, that you may need something like the shock wave that we used. And then number 2, it will correctly measure the actual dimensions of the stent to tell you exactly what diameter and length stent to use.
So we might have used a 4-millimeter balloon. With the next renditions of this, the next iterations of this, it might tell us you used a 4-millimeter balloon, now go up to a 4.5-millimeter balloon or a 5-millimeter balloon to optimize your results. So we get real-time feedback. It's nice to have Dr. Pedalia, in there. It's nice to have Dr. Shaw in here. But if I were here by myself, this would be giving me real-time feedback as to what the next steps are.
Wow, amazing.
So wait a minute, you want to have some fun? Bimmel, can you do a 3D? Look at this. So Bimmel, do a 3D rendering for us to show the kind of images you get with this.
Exactly. So let me make this picture a little bit bigger if I can. Here we go. So as we move through this vessel, and I'll zoom in here, you can see the actual wire that has been placed into the artery.
Now that's that tiny wire. Fluoro, a minute. That tiny wire you see running the length.
Right.
Now, show them the wire on your 3D imaging.
Right through here.
Yes.
This straight
Isn't that
line
amazing?
here.
This small right here.
That is the stent, or is that
That's the
just-
wire.
That's
That's
the wire that we've been using.
That's this. If you
Right
can,
here.
if you
Yeah.
can zoom in on the table, the wire that's running through the blood vessel is about as thick as one of our hairs on our head, and that's what you're seeing on the screen. That big wire running through the vessel.
That is so incredible. That little piece is what's pretty much helping us.
0.0014
Yeah,
millimeters.
this is 14 thousandths of an inch, and that's what we can
Oh
see
my
on.
gosh. Okay, so now he's moving up, and we see the.
Now you
like
see the
what part?
stent.
That's the stent.
So these struts is what we call it, is of the metal stent that was placed. And you could see on this 3D image that it's nicely hugging the wall of the artery
Looks
as well.
beautiful.
And that's what we really want to have.
That's what we want to have. Okay, we are going to take a final picture, and then I think we're going to take some questions.
Yes.
All right, let's see what we have. Last picture. Looks phenomenal.
Beautiful.
The chance of this closing is extraordinarily low, and I got to tell you, it is always
It's my pleasure to work with
fun working with you, Bimal. I always get a lot out of what you teach. Look at that other image that,
That is just
Dr.
amazing.
Pedalia is showing us now. That's right down the barrel of the blood vessel.
The before and after is very impressive here.
Yeah. Wow.
That's the Ant-Man swimming through the artery.
There it
right
is.
there.
All right, so we're going to take a final picture with all of the equipment out. Wow, that's beautiful. Look at that.
Gorgeous.
Now,
Okay.
remember that we went in through the wrist. Can you zoom up here? We went in through the wrist. So we're going to take this band. Maybe you can zoom in on our TR band. We are going to take this band, wrap it around his wrist, take the catheters out. We're going to do that so he doesn't bleed. When is he going to be able to get up?
Almost immediately, right after the procedure, in a
Wow.
few seconds
and,
here.
And
Yeah.
when are we going to send him home?
Later on today, this afternoon, if everything looks good, he should be able to go home.
That's amazing. That's incredible. So
That was the patient cheering.
so as we step over here, okay, if a stent has been put in and someone needs another one, do you take the other one out, or you just put another one in place of it nearby?
That's a very good question, and sometimes when the stent closes, we do have to telescope a new stent inside the old one. And that's the key point. We never take the stent out, but if this stent closes, we telescope a new one in, and we will try and expand this. But all the time, when a stent closes, there's got to be a reason. So when that happens, we always use that OCT or an ultrasound camera to look and figure out why the old stent closed. Was it underexpanded? Was it malplaced when we put it in? So it'll be very important not just to use X-ray, but to use those specialized camera like Dr. Pedalia just demonstrated when a stent closes. We never pull the old stent out, we just telescope a new one in and overexpand it.
Okay. Can you do a stent after a bypass surgery if someone needs to?
All the time, absolutely. Very often, patients who had bypass surgery in the 90s or even 20 years ago, bypass grafts do have a rate of closure. Some people say 2, 3, 4% a year. When bypass grafts close, we can either go in and stent open the bypass graft, or we can go in and open the original vessel, the God-given artery that was originally bypassed. So it's very often that we do these types of procedures on individuals after they had bypass. Now, I want to be very clear. Bypass surgery is a superb technology, and it's been around for 4 or 5 decades. But I think it's a complementary technology with stenting. Dr. Shaw and I and Dr. Pedalia sit down with our surgeons all the time and determine, is this patient better for bypass or better for stenting?
So the difference between a man and a woman having this procedure, because we know that heart problems run differently.
Well, first of all, the symptoms leading up to this procedure, as you and I have spoken, can be very different. So you must be very vigilant when you are determining if a man or a woman needs a cardiac catheterization or a stent procedure. The symptoms leading up to this can be different. The biggest differences we see between men and women in the cath lab is arteries on men are a little bit bigger than the arteries on women. And that's why it's so important to take all of these steps, do all of this imaging to make sure you're perfecting the stent procedures. The only other thing I would say is, some of these patients can have bleeding complications. We're putting a hole in an artery, we're giving them blood thinners. Women tend to have more bleeding complications than men. Elderly women have more bleeding complications than younger women or younger men. So there are some differences in the procedure, but you want to be compulsive and meticulous about your work, being very careful, paying attention to everything going on in the room. It becomes second nature for Dr. Shaw and I doing these, so many of these procedures together. Like I said, sometimes we may not even talk during the procedure. Each one of us has a role, but you must pay strict attention to everything going on in the room.
I'll turn this one over to Dr. Shaw here. What about the social economics and difference in, of course, heart disease and what you guys do?
Yeah, unfortunately, many people avoid care for a long time for their cardiovascular health. And oftentimes people who don't have access to health care, people who may not have access to health care come in at a later stage in their heart disease. And so they oftentimes need more therapy because they've already had severe blockages or are not on the right medications already, or their blood pressure, diabetes is not as well controlled. And so I think we've learned that we need to be more proactive at preventing heart disease. So in those particular communities, we look very heavily in making sure that they're on the right medications, doing all the right things that they can do to prevent heart disease.
Yeah. The most important thing for us to do as we go forward is to recognize those discrepancies in healthcare between different populations in this country and rectify that. I can't think of anything that we're more committed to and that's more important.
1 in 4 of us will die of heart disease, so it's important for all of us to make sure that we lift each other up.
Yeah, I think after seeing a procedure like this, I think it makes everyone feel a little more comfortable about what's going on because it's not opening the heart up as we're so used to. It's now just a very easy procedure there. And you're saying that this patient will be able to pretty much be back out there and to really work on making sure they don't have to be back in here.
Absolutely. This gentleman should be out of the hospital today. He'll be sitting up nearly immediately after this procedure. And then he's going to follow up with Dr. Shaw in the office and all of the important things about cholesterol reduction and making sure his blood sugars are excellent and that he's in cardiac rehabilitation and exercise program for 12 weeks. This is only the beginning. There's a number of steps after this for maintenance of health.
Well, it's amazing. Well, Doctor, again, you and your team have made someone, again, love life and be able to go do things with their families and stuff.
Well, I want to thank this whole team in here, all of our clinical support from Siemens, from Abbott's, from Shockwave, all the different groups that have helped to support us doing these live cases, and it's always a pleasure to work with this guy.
So it's crazy.
Nice to see you guys again.
There you are, another procedure done, thanks to Dr. Rizik and his wonderful team. So there we go.
Thank you.